A quick warning before we get started. This episode contains sensitive conversations about the medical treatment of severely ill infants and children. It may be a hard listen for some.
I was a pediatric nurse for about 12 years, and I worked with technology-dependent children. Over half of them were severely premature infants. They were born somewhere between 23 and 27 weeks gestation. 50 years ago, a 24-week gestation preemie wasn't called a preemie, it was called a stillborn.
The average pregnancy is 40 weeks long, which means the children this woman treated were born just over halfway through gestation. As a pediatric nurse, she treated these kids not only in the immediate aftermath of birth, but also in the weeks, months, and years following, if they survived that long. It's a painful and difficult road. And our guest has complicated feelings about what it takes to keep these babies alive.
In pediatric and healthcare in general, we're victims of our own success. Kids that didn't used to survive, now they can survive, but they're going to have chronic conditions that have to be treated throughout their whole lives. We start to question ourselves whether or not we actually did the right thing by saving them.
In order to share her story, this woman has to be anonymous. I also don't know her name. She still has her nursing license, but she's left the bedside. The work took a toll, and she still carries it with her.
I feel like the only stories anyone ever hears are the exceptional stories. They don't ever just hear, this is what typically goes on. And, I want people to have that as well.
My name is Sarah Kay, and this is Sincerely X from TED and Luminary Media. Throughout this series, we hear stories from anonymous people, each helping to reveal an idea in hiding. Medical technology today can do extraordinary things. Doctors and nurses can bring people back from death, resuscitated and kept alive on breathing respirators and feeding tubes. But survival does not always mean a full recovery. Patients can end up suspended somewhere between life and death, their loved ones tasked with making difficult decisions. In the case of extremely premature infants, our guest believes parents are not adequately prepared to make these decisions. Medical practitioners and ethicists discuss and debate this, but sometimes it can seem that patients and their families, the very people affected, are left out of these conversations. That there's a disconnect between what modern medicine can do and how it's being communicated to the rest of us. So, how can education, ethics, and outreach catch up to the technology? With the help of our anonymous guest, that's the question we'll explore today.
For most of my career, I have, stayed up at night rocking these kids to sleep whenever they're screaming and crying and nothing will make them happy, not even being held by somebody. We sing them songs at bedtime, we tell them stories, we give them their baths. Nursing is a very personal thing. You're taking care of people that are completely helpless. I've spent years taking care of these kids that nothing I do makes them feel better. They're hurting. They've given up long before anyone else does. And they don't get a say in any of it. And it definitely stays with you. It follows you.
Let me stop here for a minute and give you a little context. Let's say you've recently found out you're expecting a baby. You're excited, overwhelmed with information, and still months away from birth. Plenty of time to plan and prepare, but then something unexpected happens. You go into labor early. At 23 weeks, your baby is still growing. Her lungs aren't developed, she can't breathe or eat on her own, and her heart can't beat on its own. Every day she spends in the womb is crucial for development. To deliver so early means all that development has to happen artificially, outside the womb, in the neonatal ICU. And it's not at all a given that she'll survive the days, weeks, months of surgeries and procedures. At this moment of premature labor, you're given the option to sign a DNR, do not resuscitate, or to do everything possible to try and save the baby.
And you're just like, yes, please save my baby, without really understanding what you're asking for. They're going to be resuscitated. When you do CPR, you have to squeeze their chest enough to make their heart beat for them. It's painful. We're going to put tubes in their throats, in their neck, in their arms, in their umbilical cord, so that we can feed them, so that we can give them meds, so that we can keep their blood pressure up, so that we can, breathe for them. We will put children through so much more than we're willing to go through. If you talk to adults, they'll say that I don't ever want a machine breathing for me. I never want to be dependent on this. I never want to be in the ICU. If anything ever happens to me, don't let them put me on life support. Adults will talk about that, but when it comes to their kids, they'll just keep going and keep putting them through it because they're not thinking about the kid. They're thinking about themselves, and they don't want to let go. As a society, we're terrible at dying, and nobody wants to talk about the what ifs when it comes to their kids. But the consequences, they end up having to make those choices whenever they're panicked and terrified. And if they had just had a conversation about it before, they would at least kind of know which direction to go.
When you're pregnant, you go in for regular scans and prenatal visits with your obstetrician. They will talk you through your baby's development at various stages. Depending on where you are in your term, you'll be given options for screenings and tests. And if you're considered high risk, like if you're expecting twins or have a prior history of miscarriage or are older than 35, for example, you'll be monitored more closely. But generally, consultations are specific to you and your pregnancy, and they tend to focus on what seems relevant to you. Rarely will you discuss worst-case scenarios in the abstract, and our guest believes this is a problem. So, what is it you think parents should know? And at what point should potential parents be educated on this?
I feel like starting the conversation before you have to is always better. But ideally, everyone would receive this education, and they would receive it whenever they are either planning their family or whenever they find out that they're pregnant. We're scheduling all of these appointments for your prenatal care. And oh, by the way, we need to talk about this also. And then people aren't being singled out because even people that are not at risk are getting this education. You don't have to do very, very specific teaching, but just make sure people understand that, the chances of survival and the risk of very, very poor quality of life change as the pregnancy progresses. And even if you could just get that across to people, then whenever they're in, acute danger, they've at least heard it before. And beyond just preterm labor, any parent should be told that they need to discuss the unthinkable with their spouse when it comes to their children. You may have to make some very difficult decisions, and you need to know what you are and are not okay with putting your child through.
So even though it's a little morbid, if a couple is talking about wanting to have a baby and they're talking about whether they want to raise their baby with a certain religion or rooting for a certain sports team, that in the conversations of the ways in which they're dreaming about raising a child, they also need to be thinking about what they are comfortable with if something goes wrong.
And you don't have to have a plan for every single specific thing, but at least have a general idea of what you are and are not okay with, what you are and are not willing to do. And hopefully it can become such a mainstream part of our dialogue that it's not morbid.
I understand the impulse to say, let's give everybody this information and let's give it to them early in the process. But do you think that that is something that people can hear? Even giving people that information, you can tell people to not eat too much sugar because that's bad for them. And you can tell everybody that. And people will be like, cool, yeah, gotcha. Or you can tell someone like, hey, you're at higher risk for diabetes, and the way you're eating is going to cause so-and-so, and we need to talk about this. And if it feels like it is more relevant to your health and your situation or the health of your potential baby, that feels like when someone would be able to hear that information more effectively.
They are more receptive or more willing to listen when it's at them. The problem is that if you just wait until it actually applies to somebody, then we're bombarding them with all these statistics and making them feel terrified and scared and worried when they already were. And then we're saying, okay, so what do you want us to do? And they've never even thought about it before. And, a lot of my parents are just rock stars, and they can take care of these kids with really, really major disabilities. They have custom wheelchairs, and they take, 30 medications a day, and they have to be suctioned through their trach, and they have to, be fed through their G-tube, and they have all this other stuff that goes on. They have physical therapy, occupational therapy, speech therapy, all this stuff, and they just handle it, and they get lots of joy and love out of the child, and they're happy to do it. But a lot of people, they just didn't understand that they were going to have to watch them in so much pain.
Is it not the case that if you opt for resuscitation and the baby goes into the NICU, it's not as though they only get one shot, right? Like there's several times thereafter that they have the opportunity to decide to allow for a natural death.
Yeah, it's not that, you have to make that decision whenever you go into labor. And that's why I always say, people need to discuss what they are and are not willing to put their kids through as far as end-of-life decisions go before they're actually in the ICU being asked. Because a lot of times once they see them on a ventilator and once they see them in a bed and once they've named them and it's all real, it's a lot harder for them to let go. And, we've tried to brand the DNR, we call it an A&D, and we say, well, you're allowing natural death. It's not that you're refusing to take care of them or you're refusing to treat them. It's that, you're letting nature do what it was already going to do.
Right.
And God bless pediatric hospice nurses because they are amazing. There is such thing as a good death, and I don't think a lot of people understand that. And there are a lot of things that are far much worse than dying. But at any point, whenever you realize that they're not going to get better and you've got a clear understanding of what their outcomes are going to be, you can always make the decision to put them on palliative care and put them on hospice. They can still live in your house. They can still get, care for everything that's going on with them, as everything is just based on preventing pain and making them comfortable and getting the most out of the days that are left. But that being said, they feel like hospice is giving up, and that's not at all what it is. It's actually a really amazing thing. But if you can make it part of the regular dialogue, you can decrease the stigma about talking about it.
And the more people talk about it, the more we remove stigma around the decisions that do have to be made in those really difficult situations.
The decision to put a terminally ill child on hospice or on palliative care is the most selfless thing that you can possibly do as a parent. You're sacrificing your own happiness, and you are coming to terms with something that does not come naturally to you for the purpose of making them comfortable and making sure that they're okay for the time they have and making sure they can enjoy the time they have left. Because there are moments of joy. They're not in a hospital gown with a bunch of wires attached to them and, getting stuck by needles and having tubes coming out of them from everywhere. They're in pajamas and they have regular blankets on them and their parents hold them and there's no machines beeping. We turn them all off. They do molds of their hands and take a lock of their hair, tie it with a ribbon and give it to them and do little things like that. And they usually have like a big cart that they'll put in the room that's just full of like pajamas and blankets and tissues and puzzles and, bubbles or whatever they can think of to give the family to just settle in. And it doesn't have to be a bad, terrible thing.
I was talking with a dear friend of mine before this conversation who is a physician, and he was telling me that he had a palliative care attending and that he got to witness the way that the attending would talk to parents in this situation. And the phrase that he would use was, many parents in this situation would very lovingly decide that this route would cause too much suffering and is not the right choice for their child. And when he said that to me, I was struck by the use of the word lovingly, and how carefully worded that is, and how much thought must have gone into that training to be able to have what is such a difficult conversation with people in that position.
That doctor spent years learning how to make that conversation. They got lots and lots of feedback, and they very carefully crafted that terminology because it is a very difficult decision to make, and it's a very difficult conversation to have. It's culturally specific, the age of the parents, the race of the parents, the background, whether or not they've got other children that are sick, their religion, all those things factor into how they're going to respond. And all those things have to make you alter the way that you talk to them. You have to talk to them all differently. And you have to make sure that they know that we're not giving up on them. And if you want us to resuscitate them, that we will do it, and we will do it to the best of our abilities. But you also have to give them permission so that they feel okay with making the decision if they want to stop. Because that's a big part of it for a lot of people. They need permission. They need to feel like it's okay and that they're doing this because they love their child, not because they've given up. I think whenever you're trying to come up with a way to talk to people, the education that you want to give people, a really great thing would be to have families of children that have died or families of children that have been premature, give input in that education because they know what they didn't like hearing and what they are and are not willing to listen to.
That's such a great idea.
And the more input that you get from people who have been there on the other side of the conversation, as healthcare providers, we can learn a lot from them.
Our guest has cared for hundreds of children for over a decade. And just as no two children are alike, no two hospitals are alike. In a minute, we'll hear from our guest about what she thinks we can learn from the hospitals that are getting it right. Then we'll talk to a bioethicist about how he and his colleagues unpack these difficult questions and how the seemingly abstract and philosophical world of bioethics can actually provide a pathway for practical changes. I'm Sarah Kay, and this is Sincerely X. Today, we've been talking to an anonymous woman who worked as a pediatric nurse for more than a decade. Many of her patients were born severely premature, children who half a century ago would not have survived birth. Now, modern medicine can keep them alive. But our guest believes there's a disconnect between what technology can do for patients and how it's being communicated to the rest of us. In other words, how do we make decisions on behalf of our loved ones if we don't understand the decisions we're making? Do you know of or have you worked at a hospital where you think they're getting this right?
The hospitals that I see that are doing it right are the ones that are willing to have family meetings with the families for any age, not just for premature babies, but any age. Whenever things are starting to look like it's not going to go okay, they'll have regular meetings with the parents where they'll have a nurse and a doctor and a respiratory therapist and a hospital administrator and a chaplain and a social worker. And all these different people will be in there that are all involved in the child's case. And you're not at the bedside and you're not rushed and we don't have anywhere else to be. And let's just sit down and talk about where we've been and where we're going and what we can do differently. And it's a really great thing because the families feel like they're in control and they're not feeling like they're being pushed one way or the other to make a decision any certain way. And, I've been in a lot of those meetings and it can be stressful and it can be emotional and it can turn into a really awful scene. But at the same time, like, we're at least making people have the conversations that they don't want to have unless we do. And, they'll offer all the options. And if they want to keep going and they want to keep treating them, then that's one of the options.
Have you talked about your feelings on this with other nurses, with other physicians or hospital workers? Like, are you an anomaly in your feelings on this, or do other people agree with you?
No, it's pretty much a general thought process. I mean, we talk about it in the break room. We talk about it during our lunches. We talk about it all the time because we see all these kids and we see so much suffering.
Is there, what is official procedure for someone who is a pediatric nurse that wants to advocate for a change in the way something is done?
Wow, that's a hard one. There's not a lot of ways that you can really, truly impact the way things are done in general. If you work in a facility that has a lot of committees and has a lot of employee participation, then you can make a big difference. But if you don't, if you just work in, a regular regional hospital somewhere that, doesn't have unit councils and different committees like that, then you can't do much at all. So it really does depend on where you are in your career and where you work and how much your employer empowers you.
Can you tell me about why it was important to you to be anonymous in talking with us about this?
Nurses are held to very, very high standards personally, not just professionally. And anything that could make them think that your decision-making skills are compromised will get your license suspended and investigated. And I mean, with my current employer, I'm not allowed to make any public talks because even if I'm not representing my employer, just the fact that I do work there would make me liable.
So even though you haven't gotten in trouble with anyone, even just knowing that you have feelings about the high number of patients who are technologically dependent would be potentially detrimental.
Certainly. Worst case scenario is somebody reports me to the board and says that because of these feelings, I may or may not have given proper care to all those patients. And they can look at the outcomes and the long-term records and everything from every patient I've taken care of for over a decade. We're talking hundreds of kids. And try and find a time where they don't think that I did everything I should have done because I didn't want to. it would call into question my practice for my whole career.
And so given that risk, this clearly is very important to you, that you still want to talk about it.
Yeah, I mean, I loved taking care of those patients and I hated it all at once, but I wouldn't change anything I did. I wish the other people that were involved knew more about what was going to happen. And people were willing to make end-of-life choices a lot sooner so that they didn't have to suffer quite as long as they ended up having to.
After we spoke, I asked our guest if I could share her story with someone who thinks deeply about the ethical, legal, and philosophical side of conversations like these.
Hi there, I'm Glenn Cohen. I'm a professor at Harvard Law School, and my area of expertise is the intersection of law and bioethics. My first response is just to applaud this person for such a courageous, open, and honest conversation about their own experience. I was actually quite fascinated that they've now left clinical care. It sounded a little bit in part from these experiences. And that's something to keep in mind here is while these dilemmas of dealing with severely premature children, infants, is very taxing on the parents and very traumatic on the parents, we should not lose sight of the fact that our healthcare providers, our doctors and nurses have emotions and have to deal with this day in, day out. And it was quite, revelatory to hear her speak so honestly about her experience.
For parents with babies in the NICU, the field of bioethics might seem entirely disconnected from the realities they're facing. So what is it? And how can it inform parents, patients, and the practitioners who treat them?
Bioethics is the study of ethical issues raised by medicine and other biosciences. And the goal really is to bring to bear philosophical and other resources to think about dilemmas raised by medicine. It's about what are the obligations and what are the responsibilities and what are the options for physicians in ethically managing a challenging situation and working with patients and with parents. This case involves difficult questions about when should life be sustained versus not, how we frame and give advice to people versus leading them to a decision versus pushing them versus informing them, and then also thinking about various values that might be involved, like the distribution of resources to people and whether they're supported or not, how people with disabilities will be stigmatized or the like. So we want to think both about the ethical questions being presented by these kinds of cases, but also the practical realities of the people who have to manage them. And part of what I heard in the conversation was when you yourself as a healthcare provider are uncertain about the outcomes, how do you advise parents who are making these momentous decisions? How much do you push? How honest, how open are you? And there I think she got it exactly right. I think the place where maybe there is a slight bit of friction is this question about whether these are conversations we ought to be having with every parent, when you find out you're pregnant, or whether they need to be more targeted for a subset of the parents. And I agree that it's helpful to have general education for people, but I'm not sure the level of intensity of this particular question for all pregnancies. There's psychological distress that comes from thinking about this kind of thing all the time. There's information overload. And there is also what's known as a problem of what's called effective forecasting. And that's a fancy word for saying we often don't know what we are going to want in the future when it comes to our emotions. So I'm maybe a little less confident than she is that kind of early on making decisions about DNRs or A&Ds are going to really hold water when we're in the moment. I think there's just so much specificity in many of these cases. And I think that there's a lot of difficulty talking about this kind of stuff in the abstract. So I think perhaps it may just be that we need more training for people in the circumstances when this arises, but maybe a little less about the ex-ante way ahead of time.
So I'm wondering, do you have a different version of this or a different idea of how it should happen or when it should happen?
Yeah, so I think for me, maybe it's slightly different in the following way. It's not so much about the when, but the who. So if we imagine all the women who are pregnant in America, right? There are things that might help us predict who's likely to have a high-risk pregnancy or who's more likely to have a high-risk pregnancy, right? These are things like, carrying twins or higher-order multiples, more likely. prior history of difficulties, more likely. I'm not a neonatologist, so I'm sure there's many other factors that are involved, including health state, maternal age, that kind of thing. So for me, it would more be about tailoring the intervention based on elements of your personal biography that make us think you are more likely to face a high-risk pregnancy rather than trying to have these kinds of conversations with everybody. And so I might be with her and having earlier conversations, but for a smaller subset of the population.
What did you think about her idea that parents who have lived through these experiences could be a really helpful resource for clinicians to learn the best way to have those conversations?
I think this is a really great idea. And actually, we've seen it kind of something parallel in another area, which is children, or parents, I should say, whose children are diagnosed with a genetic disorder, for example, with Down syndrome. And the idea that in making the decision whether to carry your pregnancy out, to expose these parents to other parents and the children who have Down syndrome and to give them a realistic sense of what it's like. And I think the ability to share these kinds of stories would be wonderful, both for the parents and for the physicians involved. Now, the timeliness and the emergency nature of some of these decisions might make that somewhat difficult in some instances. But where you can't meet real-life people, it is possible to explore this through other forms of narrative, whether they be short documentaries, for example, or even written narratives of the people involved. All that said, again, one difficulty is just the huge range of uncertainty about what the outcomes for a particular child is going to be. That you are worried a little bit about whether you're giving someone an average case, a high-functioning case, a low-functioning case, and also the specificity of the context. And I do think contextualizing this in the lived experiences of real people is an important step forward. There's also the risk of re-traumatizing people by asking them to relive this experience over and over again, right? So it may be possible, even if we can't bring out live real people here, to at least try to give a potpourri, if you will, of narratives of people who've experienced this. And fiction should be considered as well, and that I think often people can connect to emotions, even if it's not a real story, but an account that is fictional. It's a great way to access how we feel about something with a little bit of distance.
I'm really glad that bioethicists are sitting around and talking about this stuff, but the average would-be parents aren't. And the lives that are directly affected by these decisions are those would-be parents. And so how do we get the conclusions that the bioethicists are making into the hands of the people who need to know what to do and what they're weighing?
Great. So to bring this down to brass tacks, right, in the case of a hospital, one very practical instantiation of bioethics you'll encounter in a hospital are what are referred to usually as ethics committees. And this is a committee that's chartered with various people. They may involve patients, they may involve physicians, nurses, hospital administrators. And they're there to develop policies for that hospital, but also to facilitate discussion and sometimes to have to make a decision in hard cases when they arise. And these are people who've had a lot of exposure to bioethics, and they talk about it both in the individual case, but then at the national level, at the local level, they get together, they share stories, they consider what has occurred, and they ask for feedback to say how they handled something, always in a anonymous sort of way. And so one thing I would say to patients who are encountering, or to healthcare providers like your guest, who are encountering some of this friction or some of this discomfort, is to go ahead and look to see if there is an ethics committee at their hospital. There usually is. And to have a candid conversation with somebody involved with it about whether there's something the ethics committee can do. When a situation occurs often enough, it may lead to a written policy. So, my advice to people like your guest who find themselves in this situation is typically you can go to these people in an anonymous sort of way. You don't have to be identified, but to get some backup, because when you are feeling ethical discomfort, it's usually a good sign that maybe there's something worth talking about.
So it sounds like there are possible outlets for change, or at least discussion.
Yeah, although I'm very sympathetic to the idea. And again, this is the place where I think it's useful to always be aware of power hierarchies and institutions. And, we should ask ourselves whether having a system whereby she needs to instigate this conversation rather than a system where these conversations happen routinely and there is this space for these conversations, what's more desirable.
There's something that our guest said which struck me so strongly, which is, she said, it used to be that if a baby was born in the 23-24 gestational week, that baby was stillborn. And we have the technology now to keep that baby alive. And because that new technology allows for us to save the baby, but then have all these other issues that we have to solve, that we are victims of our own success. And I think a big question about this episode in general is that as we're able to do things we've never been able to do before, that is going to and continues to present new issues, especially around ethics, that we've never seen before. And is there a way for our ethics to catch up with our technology?
You're absolutely right. And these technologies always kind of show us the difference between can and ought. Just because we can do something doesn't mean we ought to. And this really intersects with this situation in two ways. First of all, the type of age, the gestational age to which we can resuscitate and sustain a premature newborn is moving further backwards in time, such that we're now able, medically speaking, to potentially save younger and younger gestational aged newborns. That's one piece of it. The other thing is that we're learning more and more about the possible lives these children will have. And I think the real difficulty here in making this decision as an individual is really twofold. The first is just an informational deficit. If you don't know what it's like to parent or to be a person with even a severe disability, you may have all kinds of preconceptions about what that life is like that turn out to be wrong. And how do we get people more information that is contextual, that is available to them? That's one piece of it. The other piece of it, though, is the difference between the social and the medical model of disabilities. So disability is a medical fact, but it's also a social fact. How well your life goes as somebody with even a severe disability is in part based on the society you grew up in. What kinds of resources are available? What kinds of adaptations for public buildings, for schools, for example, are available? And here I think it behooves us not just to think about this at the individual level of people trying to make this decision, but what we can do to be champions of people with disabilities in the world and to try to have a world that supports both the parent and these children in a way that makes their lives go better.
I had to do a lot of research to have this conversation, and I really appreciated it because this is super outside my wheelhouse, but really fascinating. And I'm a person who spends a lot of time thinking about people as like amorphous clouds of soul and not the mechanics of the human body. And when I'm confronted with people who are in medicine and in health who have to have a really thorough understanding of the human body as this machine and how it does and doesn't work and how to help and how to fix and what can and can't be done, I am struck by how different our way of understanding is and how incredibly hard the jobs are that entail the kind of work that you have done. And so I'm very much in awe of what you were able to do and able to carry for a very long time. And I'm very grateful that you were willing to dive back into it with me.
Well, thank you. That means a lot. And I think it's important also to think about that this isn't always what it's like. There are lots of joyful moments with these patients and with these kids. You know, some of them do interact with us and they know their parents and they know who we are and they know when they don't like somebody and when they do. And in their own ways, you know, they still interact with us. And, you know, there are happy, fun, joyful, exciting moments. And those are kind of like, those are the times that, you know, in between everything else that, you know, makes it all happy.
And makes it possible to keep doing the work, I imagine.
Yeah.
I hope you get to do something extremely lighthearted now.
I'm gonna go hug my niece.
Yeah, good. Do that. Bye.
Bye.
Sincerely X is produced by Magnificent Noise for TED and Luminary Media. Our production staff includes Kim Naderfane-Peterse, Destry Sibley, Eva Wolchover, Noor Waswas, and Chloe Shasha. With the help of Angela Cheng, Janet Lee, Michelle Quint, Jesse Baker, and Colin Helms. Our fact checker is Lorena Aviles Trujillo. This episode was mixed and sound designed by Kristen Muller. Our executive producer is Eric Newsom. I'm Sarah Kay, and this is Sincerely X.